Hello, my name is Mark Litwin. I'm the chair of UCLA Urology, and I'm joined today by baseball legend Steve Garvey. We're here to talk about prostate cancer from both the physician's perspective and in a few minutes from the patient's perspective. I'm going to spend a few minutes talking about the important elements of what people need to know about prostate cancer, if you either have a prostate or if someone you love has a prostate. And then Steve will talk a bit about the patient perspective, having been through an experience with prostate cancer. There'll be a time for questions at the end of our presentations, and you can submit your questions at hashtag UCLAMDchat. Hashtag UCLAMDchat. And we'll read you that again when it comes time for questions. We'll be happy to entertain those at the end of our presentations. So let's talk about prostate cancer and dive right into it. What you may or may not know about prostate cancer is that it is the most common cancer in men in this country, in fact in the developed world. And there are between 200,000 and 300,000 new cases of prostate cancer diagnosed in this country alone every single year. And despite what you may have heard about prostate cancer, it is sometimes slow growing, but it is sometimes fast growing. And in fact, somewhere between 30,000 and 50,000 men every year die from prostate cancer in this country. Many of those deaths, we believe, were preventable. And we're here to talk mostly today about the key facts that you want to know in order to prevent death from prostate cancer. So let's jump right into it. The prostate gland, as you may or may not know, is one of the male reproductive organs. It is located deep in the male pelvis. Women do not have a prostate gland. And the prostate gland's primary function during younger years is that it plays a role in reproduction and in sexual function. As a man ages out of those years, however, it really becomes primarily a problem organ. If you're lucky, it doesn't bother you that much, and if you're unlucky, it bothers you a lot. And there's several things that can happen to a man's prostate as you age. One of the things that happens is that it grows larger and it can cause blockage problems. That causes what we call urinary obstructive symptoms. Difficulty with the stream, the flow, dribbling, waking up at night, the typical kinds of problems that you hear about in older men from an enlarged prostate. And as every 9-year-old kid knows, when you go to the baseball stadium and you're up at the restroom, don't stand behind the old guy because he's going to be there a little bit longer than you want him to be. And that's a classic demonstration of the enlargement of a prostate gland in a man of a certain age, 50, 60, 70, and older. The prostate gland, however, also has the risk of becoming cancerous. Cancer cells can develop in the prostate gland and they can grow and spread from within the prostate outside to other organs of the body. And prostate cancer is the disease that we're here to talk about today. September is Prostate Cancer Awareness Month throughout the United States, and you will see often men growing beards in order to promote prostate cancer awareness. This is a program called Septembeard, which you can find online as well at septembeard.org, with information about prostate cancer and ways to support prostate cancer research at some of our nation's leading academic institutions, such as UCLA and others. But back to the prostate. As the prostate gland grows, it causes symptoms. But in addition to the growth, as I mentioned, it can also harbor nests of prostate cancer cells. Now, for many prostate cancer cells, they simply stay within the prostate gland, they brood around a bit, they sizzle along, and they never actually cause a problem at all. These are what we call the indolent or slow-growing prostate cancers. And fortunately, it actually comprises the majority of prostate cancers throughout this country and throughout the world. Indolent, slow-growing prostate cancers. If it were only these tumors that occurred in men, we wouldn't really have a public health problem because men would not experience symptoms or progression or death from prostate cancer. However, unfortunately, there is a subset of men who do not have the slow-growing indolent type, but who have the more aggressive type of prostate cancer that does tend to progress beyond the prostate and then spread throughout the body to the lymph nodes, to the bones, where it can cause painful symptoms, and other areas of the body as well. These are the cases that we are most concerned about trying to identify early and trying to prevent if we can. Because with good treatment and early diagnosis, we have the tools available in our armamentarium to knock out these cancers in most cases and prevent progression, prevent death, and in fact cure the prostate cancer. So that's one of the things that we have not just on the horizon, but in fact right in our grasp, in our hand right now, is the opportunity to cure men from prostate cancer, but only if the tumors are diagnosed early. Now, the title of this webinar is The Signs and Symptoms of Prostate Cancer, and one of the unfortunate aspects of prostate cancer is that normally, in the usual case, the typical man, he has no signs and no symptoms at all. In fact, it's sometimes referred to as the silent cancer, the silent killer, because for many, many, many men with prostate cancer, it starts early enough that there is no sign, there is no symptom. The symptoms of an enlarged prostate that we spoke about a moment ago are not related to prostate cancer. They're simply related to what we call benign growth of the prostate gland. That occurs in the same age group, but it's completely discrete. It's separate from prostate cancer. And so how do we detect prostate cancers early if that's the key to diagnosis and treatment and cure? Well, the only way really is to get checkups. And the checkups that are involved for prostate cancer, as you may know, are two critical elements. One is the digital rectal examination, sometimes abbreviated as the DRE. The digital in the digital rectal examination is nothing to do with a computer being digital or analog. The digit refers to the finger of the doctor doing the examination. So the digital rectal examination is actually a prostate exam with a finger placed through the anus into the rectum onto the prostate itself. And although the exam can be a little embarrassing, slightly uncomfortable, certainly not what one wants to do on a Monday morning, it can be a lifesaver. It can be a lifesaver. And what the physician is doing when he or she is examining the prostate, doing a DRE, is looking for nodules or hardness, lumps in the prostate gland itself, because the location of the gland is immediately adjacent to the outer wall of the rectum. So it's very simple to place a finger on the prostate and to examine it looking for a lump or a bump or a rock-hard nodule in the gland itself. That's an indication that there probably is a cancer growing in the prostate and something else needs to be done. We'll come back to that in a moment. Many times, however, a man can harbor prostate cancer. He can have a prostate cancer growing in his prostate and the examination is completely normal. That is, the tumor can be deep inside the gland, not close to the edge of the prostate, and the doctor may not be able to feel an abnormality at all, either because the tumor is far away from the wall of the prostate or simply because it's just too small to be palpated, to be felt on an examination, and the exam is normal. So one certainly wants to have a normal prostate exam, but it doesn't get you off the hook completely. The other element of early diagnosis and what we call screening for prostate cancer is a blood test called the PSA test. And many people have heard of the PSA, but there's a lot of confusion about it. PSA stands for prostate specific antigen. PSA. And it's a chemical, it's a protein that circulates in the bloodstream and it's secreted by the prostate gland. Turns out that if it's elevated, it may be an indication that there's prostate cancer going on. But like many medical tests, it's not perfect. And so prostate cancer can exist in the setting of a normal PSA. And you can have an elevated PSA in the absence of prostate cancer. So it's an imperfect test, but it's a pretty good test. And so a blood test for prostate-specific antigen, or PSA, is often recommended by doctors if we are looking for early indications of prostate cancer. That's the plain and simple truth about PSA, DRE, and what we call prostate cancer screening. Now, there's a lot of controversy about prostate cancer screening, and if you read much in the media or watch much on the media about prostate cancer screening, you'll hear different groups with different opinions about whether men should or should not be screened for prostate cancer. And there is earnest debate about the usefulness of prostate cancer screening. And the reason for that is that for many, many men, if they have the indolent, slow-growing type of prostate cancer, well, really then there's no benefit to making a diagnosis. Because if a patient has a low-grade, slow-growing tumor and is already in advanced years, 75, 85 years of age or older, then really it's unlikely he'll benefit from being screened, diagnosed, and treated for prostate cancer. Conversely, even in a younger man, if he suffers from many other medical conditions, severe problems with the lungs, the heart, the kidneys, diabetes, things like that, well, in fact, a slow-growing prostate cancer may not be on the front burner in terms of medical issues for him to be concerned about. And so one doesn't want to simply willy-nilly go in and get prostate cancer screening. It's a decision that a man wants to make with his doctor, with his partner, family, advisors, etc., about whether prostate cancer screening makes sense for him. But given that he decides that he would want to know if there were a cancer there, then that's how prostate cancer screening happens. A DRE, finger exam, and a PSA blood test. All very simple. Once these tests are done, then the patient is said to either be at increased risk for prostate cancer or not. And so if there's a lump in the prostate, or if the PSA is elevated, then the patient has to decide, does he want to go ahead and have a biopsy? A biopsy of the prostate is a minor outpatient procedure. It's done under local anesthesia, so you come in and you leave on the same day, usually within half an hour to an hour or so. And a needle is placed under local anesthesia through the rectum into the prostate gland, and a small core of tissue is extracted. And usually we take several cores of tissue so as to minimize the chance of missing anything. Those cores of tissue, which are about as big as a lead from a mechanical pencil, are then sent off to the pathology lab, and they're analyzed, and we determine, is there cancer there or not? Again, like all medical tests, it's not 100% accurate, but if we find the cancer, then we know we've got something to deal with. The pathologist then grades the cancer onto a numerical system, something that's called the Gleason grading system. It's a 10-point scale that tells us how severe the cancer is. Most cancers are in the lower end of that spectrum, and in fact may not even need to be treated at all. But there is a subset of tumors that are on the higher end of that spectrum for which we're happy we did the early diagnosis, because that may in fact be the only thing that saves the patient's life. So if it's a high-risk tumor in a healthy patient who has many years ahead of him, then the decision-making is undertaken with the physician about whether treatment ought to be instituted. And there are a variety of different treatments for prostate cancer. There are surgical approaches, there's radiation, there are medications, and in some cases, in fact many cases today, we do what's called active surveillance, which is where we watch the patient, monitor him very, very closely for signs of the prostate cancer progressing or advancing, and then revisit the issue of treatment later on in the course. But again, there is a fraction of patients, a sizable fraction of patients, for whom the prostate exam is normal. The DRE shows no abnormality, and it's only that PSA that's elevated, a little elevated, sometimes a lot elevated, that prompts the biopsy, which can in turn identify a high-risk, high-grade cancer that really does need to be treated. So then there's a process that the patient and his family go through with the physician, urologist, radiation oncologist, medical oncologist, primary care physician, perhaps others, to decide what's the best treatment for me. Because it has to be customized. It has to be personalized to the patient's individual situation. Some men have different relative priorities for length of life versus quality of life, elements of the quality of life. For some men, their other medical conditions impact whether they ought to be receiving radiation or surgery or no treatment at all. So all of this is very personalized, and it makes a big difference where you are treated. Prostate cancer decision-making and treatment must be undertaken with a physician and a team who are extraordinarily experienced, up to date on the latest and most cutting-edge technologies in both the surgical and radiation and surveillance approaches, and a set of physicians who really can personalize the care to that individual patient and to his spouse and his kids and his family. So that's very important. Where you're treated makes a big difference. So I won't go into the specifics of different types of treatments. That's really beyond the scope of this webinar today, but where you're treated makes a big difference, and that is important. A few words before I finish about different risk groups for prostate cancer. We talked about the fact that some men ought to be screened, some men might not want to be screened, but there are two high-risk groups. And those high-risk groups are, number one, men who have a family history of prostate cancer. So if you have a brother or a father with a history of prostate cancer, that puts you at a higher risk for having the disease as well. And so that needs to go into the decision making. And men who are of African ancestry, African American men, typically are thought of as having a higher risk, 2 or 3-fold higher risk of developing prostate cancer. And so they too ought to really give serious consideration as to whether prostate cancer screening, diagnosis, and treatment might be right for them. Those are the two high-risk groups. As for diet and prostate cancer, to try to anticipate what many of the questions often focus on, there's a lot we know and there's a lot we don't know about diet and prostate cancer. And we could do a whole hour just on that. But there's plenty of good quality information about diet and prostate cancer, and there is felt to be some impact of diet and certain elements of the Western diet, what we refer to as the Western diet, that's typically high fat and high processed foods, that we think may actually have an impact on the development of prostate cancer and on the progression of prostate cancer. But to sum up then, before I introduce Steve Garvey, the most important thing, in my view, as a physician who cares for men and their families dealing with prostate cancer, is to get to the right medical center and the right doctor for you, someone with whom you have a personal connection, who you can really talk to and who will talk to you, someone who has time for you, to sit down with you and to really help you work through the issues of whether you should be diagnosed and screened, and if so, whether you should be treated or not, and if you're going to be treated, what treatment to choose, and then on through the trajectory of prostate cancer. So Prostate Cancer Awareness Month is September. This is a time for us to encourage men and those who love men to think about getting their prostate glands checked with the DRE and the PSA, and then make decisions based on that. So I'll pause there, and it's my pleasure to introduce my friend and now media colleague in prostate cancer awareness, Mr. Steve Garvey, formerly number 6 on the LA Dodgers, who will talk about his perspective in prostate cancer. Steve?
Okay. Doctor, thanks so much. It's a pleasure to be with you today, and also to have my new best friend give you a presentation and in-depth understanding of prostate cancer. I'll talk about 3 things today. I'll talk about history of prostate cancer in my family, my observance, detection, and then involvement here at UCLA Urology and with Dr. Litwin, the procedure that I went through, the success we had. And the third part is what happens when God throws you that curve and you're just fortunate to have a great team to hit it out to right center as we speak, and what you do with this opportunity. First of all, you may notice my beard. You may have said that can't be Steve Garvey, he's got a beard. But because of this experience with prostate cancer, because of being a disciple now, to create awareness and do everything I can to be part of UCLA Urology and its progress and destiny and history, September beard is something very unique. And it's a lot of fun. I went to Dodger Stadium last night, and people all wanted to take pictures with me because they thought that this may be the only time they'll ever see me. Well, every year from now on in September, I'll have this beard, because what it'll stand for is my belief in prostate awareness, and that we can make a difference, especially at UCLA. 20 years ago, when my dad was 64, he had a radical prostatectomy in Temecula, California. I was 44 at the time. And it began my understanding and my research into what prostate cancer was. And this is typical of anything, I think, that strikes those people that we love. We want to learn more about it. We want to understand it more. Can this genetically affect us if it's within our own family? And what can we do to prevent the possibility in the future? So from that point on, even at an early age, I would say at 45, 46, I started to take my PSA as part of my blood panel with my annual physical. And then all of a sudden, spring of last year of 2012, after my blood panel, I noticed that my PSA had escalated. I had been having some problems urinating, had been getting up at night, but a man 64 is going to have this happen. It wasn't radical, but I was noticing it. So my doctor, Dr. Svetlana Rupakovich out in Palm Desert, said, let's wait a couple months, take another test, and let's see if there really is momentum as far as your prostate PSA is concerned. Took another test. It was increased at that time, and we talked, and she knew that I had a deep relationship here at UCLA on the board of advisors in neurosurgery. I had one hip replaced. I guess I'm working on my way through every department here at UCLA, and gladly, because my trust is here. And we contacted UCLA Urology, and Dr. Mark Litwin met with my wife Candace and I about a month or so later. And he sat down with us, and I started to understand what is essentially the strength of a great physician. And over time, I realized it's a lot about the head, understanding the specifics of what they're dedicated to, in this case, urology. It's about the heart, how you deal with your patients, how you deal with your staff, your leadership, the comfortability that a patient has as they understand that there is mortality in their life, and they're staring it straight in the face. And then the hands, that eventually we decided to do a radical prostatectomy. But to go back to that first meeting, as always, the women in our lives ask the most questions, and Candace asked, I think, 10 to 1. And before we got there, Dr. Litwin did say one thing: don't go online. Don't go digging as deep as you possibly can. Let's meet first, and let me explain it to you face to face, one-on-one, and give you a personal, in-depth understanding of what you may be going through. Another baseball term, I played baseball, I hit a baseball, but you don't want a prostate the size of a baseball, and that's what mine was rapidly growing into, which means there are significant danger signs. So Dr. Litwin said, well, let's take a biopsy. Let's see if indeed there is cancer, and to what degree, especially with the Gleason scale. So I came back a few days later and did the biopsy. 2 days later, and I'll never forget this, I'm watching my 13-year-old son. He's practicing football on a beautiful field, late afternoon in Palm Desert, California. And I'm sitting on a bench, and the phone rings, and I pick it up, and it's Dr. Litwin. And at this point in time, that bright sun all of a sudden starts to get darker, and you start to get a tingling. And this is the moment that you're going to determine or find out if you do have prostate cancer. And very mildly and with a casual tone, Dr. Litwin said, Steve, I want to inform you, you do have prostate cancer. But I also want you to know that in my heart, I know we can beat this. And all of a sudden, the clouds started to part again. And he gradually talked me through what we should do next. And that was to have a meeting to determine what we would do. So a week or two later, we came into the office, and he categorically went through what we could do. We could do seeding, we could do radiation, we could do chemotherapy, we could sit and watch. But as always in my life, I've always been proactive with my challenges. And I looked at him and I said, what about a prostatectomy? And he said, there are two ways to go about it. We can go about it robotically. And then he looked at me, and I've seen this in the face of a lot of confident Hall of Fame pitchers, and I knew I had a challenge. And this time, there was this feeling in my soul and my heart that this man really had my best interest. And he said, but you know what, Steve? He said, I'm at the top of my game. Let me do it. I'd love to hear that. And I looked at Candace, and she had a big smile on her face, and let's do it. And then we scheduled a morning for the operation. We came in early. We were handled perfectly by the staff at UCLA at Reagan Hospital. Went through the procedure, took longer. The prostate was very large. Dr. Litwin came into my hospital room later on in that day, and he looked at me. He said, "A little tougher. We lost a little more blood." He said, "But he said, I'm very optimistic." And then he came back with the tests, and a day or so later, and he said, "Well, I believe it's encapsulated. I believe it hasn't spread." He said, "Let's not do anything at this point, but wait 3 months and take a PSA and see where you are." And both Candace and I were squeezing our hands, and I think I may have grabbed Dr. Litwin's and his staff, and we did just that. I went through the process of healing. It's not easy. The catheter is going to be there for a while. You're still going to have anxiety. The recovery takes patience, which is not easy in most men. But if you are patient, if you do have faith, if you put your confidence in your doctor, as I did in Dr. Litwin, then the process is going to be much easier. And I think in the long run, what's in the soul and in the mind inevitably does have an effect on the body. In 3 months, we took a PSA, came back 0.1 negative, and the doctor said, "Well, I think you're clear." We're guardedly optimistic. I'll continue to take a PSA every 6 months just because, and I think it's the right thing to do. But from that point on, I've been a disciple of UCLA, of the urology department, Dr. Litwin, and what their challenges are. And I guess the third part of my statement is, again, when God does throw you his curve, and through the grace of God and prayers and the great hands of a surgeon and staff, and you come through it, and the skies do part, what do you do then? Well, with that challenge comes responsibility, and from that point on, I would say starting in February, I've done over 60 interviews of radio and television and online. We're creating projects and programs right now that are fun, that are entertaining, that are educational, but that are going to be beneficial to UCLA Urology. And this is ongoing. It kind of starts with the beard as far as a physical contribution. Again, my first one, found out I do have gray hair. I am 64. I may have to put a little for men only on it. I'm not sure, to make myself look younger. But everybody that saw me at Dodger Stadium last night took pictures because they said, you're never going to do this again. But I am. Every month, September, for the rest of my life, I'll do this just because I want to make a statement. And we'll get others to make a statement. Because there's a problem with us men, in that a lot of times we're in denial. A lot of times we don't want to face our physical challenges. We want to solve the world's problems, but we don't necessarily want to serve ours. And it's important to us. I spoke at a large Cancer Society dinner in Palm Desert a few months ago. And it was men and women. It was a wonderful evening. Everybody was so well dressed. And I told all the men there to take a look at that woman they love next to them and to tell her that you're going to do everything you possibly can to make sure prostate cancer doesn't take you out of her life. And I saw a lot of men look at their wives, look at their girlfriends, even look at their daughters and mothers and make a small statement. But that's what we need to do. We need to be foot soldiers. We need to be disciples in prostate cancer awareness. And again, to work in the field, in the clinic, in the hospital to make a difference. And as Dr. Litwin did say, the early detection and the amount of success is directly proportional. And I've lost friends and I've lost family members to prostate cancer. So it's an honor to be with you today. I am a disciple. I will and always will be. And I want you to look in the future and to go on our site to follow what we're doing and how you can participate. And it may be only in thoughts and words to share with others. It may be in dollars and cents. It may be to join us in events we're going to do. But let's do this together. Let's fight prostate cancer. Let's make a difference. Doctor.
So questions from listeners or viewers about prostate cancer.
You got the glasses?
Yes, I'm going to try to do it without the glasses today. We have a question here that says, do you agree, I think this one is for me, do you agree with the AUA, that's the American Urological Association, their recommendation, no routine screening before age 55 or after age 69? And the question refers to some of the controversy I mentioned, that many medical groups, doctors' groups, have promoted the idea that if you're too young, you don't need to be screened for prostate cancer because you're unlikely to have it, and you just end up generating worry. And if you're too old for prostate cancer, that really something else is going to get you first. And so you ought not worry about prostate cancer so much. And the general feeling here at UCLA Urology, and in fact at most academic medical centers around the country, is yes, that for men who are too young to be in the age group for prostate cancer, it doesn't make sense to be screened routinely unless there's a specific risk factor. As I mentioned, family history, African American race, those put you at higher risk. And then for older men in the 70s, 80s, and beyond, PSA and prostate cancer screening doesn't make sense either for them. So although the recommendations are evidence-based, they are still somewhat controversial, and different medical physician groups have different opinions about this, but this is where the field is kind of coalescing today, that not every male at every age needs a prostate exam, but in the high risk group, the target age group for prostate cancer, that screening ought to be done, and it ought to be done in an informed way with the advice of a physician about how to proceed.
Doctor, let me ask you one question. It just a check in the box for your PSA test when you're taking your blood test, am I correct? So why not, when you are in your 40s, just to check the box just in case? I mean, how early have you detected prostate cancer?
Well, it's a very good question. There are prostate cancers that occur in men in their 40s. And these are the cases often that we're really glad we found, because you have a man in his 60s, and you'd like to think that there's a lot of years ahead, but for a man in his 40s, presumably there are at least 20 years more. And so if there's a high-risk case, particularly African Americans, men with a family history, there is a lot of evidence and a lot of opinion for sure suggesting that a PSA in the 40s, even if just as a baseline, ought to be taken so that men can make informed decisions. So
Start
it's not a
base
bad
early.
idea. Correct.
That's what I believe
Correct.
in. I did at 45, 46.
Right. The key is don't be driven by the decisions, but by the PSA, but let the decision making be driven by the patient and by discussion with the doctor. Here's a question that came in, and it says here, I think this is directed to you, because it's what's been the most difficult part of this diagnosis for you?
Well, I think, again, like I said before, your own mortality. I was known as the Iron Man when I was playing, and played 7.5 years straight, and was very rarely injured. And then once I retired, started getting a little arthritis, and you start to realize as you get older, things are going to happen in your life. Especially for men, there is that possibility of prostate problems. So I think it was when you made that call and you said, I did have prostate cancer, those words, that you have cancer, now you realize it's you. I mean, we've had a number of members of my family have had cancer, friends, and now it's personal. I mean, now it's you. And how do you put it in perspective? It took me a little while. I've always been one of those people that could compartmentalize, and I guess maybe that's what happens when 60,000 people are booing you at a stadium somewhere and you can't take it personal and you got to do your job. But now it was cancer in my body, and I had to wrap my arms around it. I had to put it in a certain spot. I had to take my faith and use my faith as my strength, and my family and my wife and children, and then go about what I needed to do to address that cancer and to beat it.
One of the advantages of being the doctor in this situation is that if I'm in the operating room and one of my fans starts booing me, I just kick them out.
That's
right. Kick them right out of the stadium.
And when your attendance boos you,
that's right. Kick them right out. I only want the affirmative fans there. There's another question that I think is directed to you, Steve, that says, is there anything that you feel like, in retrospect, anything you would have done differently in your process of either diagnosis, decision making, sort of how it all played out? Would you do anything differently?
That's a good question. Because of the transpiration from when I started taking the PSA, then knowing the escalation, there may have been an earlier sign a year ago that I just avoided, because I didn't think the number was high enough, because I wasn't knowledgeable enough to know that, is it 4 dangerous? Is it 15 dangerous? All I knew was if you start to get those higher numbers, then you've got to really address it. So I wasn't knowledgeable enough to be able to make a decision then to maybe take that first step a little sooner. And that's why we keep talking about early observation, early going through your PSA, making sure that this is one thing that we can catch early and that we can defeat. but you need to be proactive with it.
And of the education that you did for yourself, you and Candy, how much of it was just through interaction with us at UCLA versus how much talking to friends or colleagues or digging into the internet yourself?
Well, it's interesting because of now I guess being a spokesman for prostate cancer awareness and having done shows all over the country and even the world, men come up to me, and I travel a lot. I'm a cancer survivor. I have prostate cancer. I'm doing this or I'm doing that. And we talk. I missed a plane probably about 3 months ago because we kept talking. This man needed somebody to talk to. He had his wife and he had his family, but he needed to talk to me as a brother, so to speak. And I think it's very important, this conversation, this dialogue that we need to escalate so that we can. And from those early interviews on, I've actually grown an understanding of prostate cancer. What you said, I thought I knew that, but all these other little nuances that you don't know unless you talk about it, and what people have gone through has made me much more knowledgeable now. But it's about the dialogue, it's about the conversation, it's about the profession.
Continual learning process.
Absolutely.
Here's another question from the internet. Is there anything I can do to prevent prostate cancer? I'll take that one.
Take it.
And the answer is yes and no. The evidence is soft on prostate cancer prevention. There's a lot that's been investigated about certain supplements and dietary modifications, and the data that have come back in are not overly convincing about whether you should take certain vitamins, avoid certain foods, take certain foods. The general consensus on sort of second tier level data is that a diet that's low in fat, high in fiber, and we think a diet that's high in soy products is probably preventive against prostate cancer. So these are things that a person can do. There was a big study looking at selenium and vitamin E a few years ago that some of the major academic centers were involved in, including UCLA, and that turned out not to be helpful. Selenium and vitamin E. There was good initial evidence for it, but it didn't work out in terms of prostate cancer prevention. There is medication that men can take. There's a type of medication called a 5-alpha reductase inhibitor that men can take that have been shown to prevent many cases of prostate cancer very, very effectively, decrease the risk by 25 or 30%. And so many men choose to do that. So you could talk to your doctor about that if you're at a high risk group. The problem with 5-alpha reductase inhibitors, such as finasteride and dutasteride, is that they tend to prevent the low-grade indolent cancers, and they don't tend to prevent the high-grade cancers, which are really the ones you want to prevent. So there's a lot of mixed evidence about that. There's an article in the New England Journal of Medicine recently about that. That you can pull that's free to users of the internet. So the question, is there anything I can do to prevent it? Diet that's low fat, high fiber, high soy may be helpful, but the evidence is kind of soft. Certainly that's a window of opportunity to improve your risk profile for other conditions like heart disease and colon cancer. So that's important.
And from somebody who's made a living out of using their body in sports and then carrying on, realizing that there was life after sports, and I needed to stay in shape. I needed to do cardio exercise, needed to lift weights for skeletal and muscle structure and so forth. All these things I think are a contributor to good health, along with what Dr. Litwin said was a proper diet, laugh once in a while. Don't take life that seriously, and it will contribute not only, I think, to the physical element of our lives, but also the mental element, which I think is always got a significant influence on us.
Don't sweat the small stuff.
That's right.
That's
Absolutely.
what I've learned that as a survivor, a long-term survivor of cancer myself from my younger years. I learned that as well. Don't sweat the small stuff. As I say to my 13-year-old twins, there are some things in life worth getting really upset about, but not many.
We call it pick your battles.
That's right. Yes.
That's right. Especially you, those of you who have kids, you know that.
You must have had 13-year-olds at some point, too.
Absolutely.
Exactly. Next question here, how often should I be screened? So if you have decided to be screened, then the general advice, if you're in the risk group, you're in the age target range, is to be screened once a year. That's the general advice. There's some newer information coming out now that indicates that every other year screening may be appropriate if the PSA level is really low and well into the normal range. But most people will say that if you're going to be screened, annual screening is the right interval. Another question off the internet. I think this is also aimed at me. Why are African Americans at higher risk? The answer is we don't know for sure. Like all cancers, it will probably end up being determined at some point in the future that it is genetically controlled. And so it's probably something in the DNA that's a little bit different. It may be something about the way that different racial groups process certain hormones, in particular the steroid hormones or testosterone, that puts certain groups such as African Americans at higher risk. But the fact of the matter is we don't know with definitive knowledge exactly why African Americans are at higher risk, but they are at 2 or 3 times higher risk of getting prostate cancer. And then once they have it, they're at 2 or 3 times higher risk of dying from it for a variety of reasons. Next question here is directed at you. What this is kind of an open-ended thing here, but what specifically helped you get through the diagnosis and the process?
Oh, I think faith. I think in realization that, there are things we can control in life and things we can't control. I talked about that curve that God throws us from time to time. We're all fallible. There's no reason why cancer should discriminate against certain people and not others. I think we're human beings, and it happens in life. Let's not blame anybody. Let's not play the blame game even on ourselves. It happens. We put our arms around it, like I said before, and now let's address it and go from there. A lot of times, especially in the situation of sexual activity, it's always the first of 2 questions that men ask me. Is it going to affect me sexually? I mean, is this going to seriously jeopardize my sex life? And I'm going to be straightforward. It can, it may. As a rule, it does, because this is an operation that's in a very sensitive sexual area of males. But there are a lot of things that can be done to bring you back to a robust and active sexual life. But again, you have to listen. You have to be patient. You have to be disciplined. You're going to be frustrated because we're males. We have testosterone. Sex in our lives is very, very important. But again, you take this area of what you're dealing with and you give it to your doctor and his associates, and then they'll tell you what to do. They'll give you the best advice. They'll help you along the path to recovery. But don't let this deter you from addressing the challenge of prostate cancer and the possibility of losing your life just because you're more concerned with your sexual life and not your real life.
Great answer. The next question is about the specifics, and the questioner wants to know, what was your stage, what was your Gleason score, what was your PSA when you were diagnosed?
Well, I think we had a couple areas that were 7s. We had a couple of 6s. I think we did 8 areas. I believe. Right. Just saw the doctor that did the procedure.
Dr. Pantok.
Dr. Pantok, yeah. So once it got to 7, I think that's when you determined that we needed to be aggressive and active.
That's right. The stage was what we call a T1C because the exam was normal. The PSA was slightly elevated, not crazy high. It was that grade 7 that really said, this is not an elderly, sick old man. This is a vigorous performance athlete who's got many years ahead of him, and we need to treat that. Yeah. We need to treat that. Well, I think to wrap up and finish on time here, we'll think about closing. I'll ask you maybe for some final words of wisdom, and I'll tell you my final words of wisdom from the physician's perspective are as follows. If you have a prostate, or if someone you love has a prostate, and that prostate is somewhere between 40 and 70 years old, think about whether it makes sense for prostate cancer screening to happen with a digital rectal examination and a PSA. Think about it yourself. Go and talk to your primary care physician. Go and talk to a urologist if that's appropriate, and make a decision together. And then if you have a biopsy, and if you are unfortunate enough to be given a diagnosis of prostate cancer, take a deep breath, pause, don't feel rushed. Take the time you need to make the informed treatment choice that you need to make with the input of your primary doctor, your urologist, perhaps a radiation oncologist, or other physicians, friends, colleagues, etc., and make an informed choice, one that is tempered and thoughtful and is the right choice for you, because decisions for prostate cancer treatment or not treatment really can and should be customized to the individual. And if you're not at the right medical center or not with a doctor that you feel comfortable with, get into the right hands and don't feel the pressure to make a decision before the sun sets. Prostate cancer, even in its worst case scenario, is a disease that affords you the time to make a thoughtful, informed decision about what to do in terms of treatment going forward. And Steve, I'll give you the last word.
Thanks, Doctor. And for us here at UCLA, it may be a local game, but it's global recognition of the things that are being done here at UCLA Urology to change the game, so to speak. Another thought, and that is women have done a fantastic job in awareness of breast cancer with Susan G. Komen and all the programs and foundations and the pink ribbons. And we support our women and we want the best for them, and we stand with them and we walk with them, and we talk more than ever because it's our wives and daughters. But it's time for us men to gain momentum, to take our blue ribbon and to be involved at UCLA Urology, at the Prostate Foundation, at programs all over the country and the world, and for us to make a difference now too. If this is a problem you have, we're with you not only in spirit, but physically here. You have me as a brother and many athletes and entertainers and neighbors around the country are there to support you. So God bless and best of luck. And what's the word? Carpe diem?
Carpe diem.
Seize the moment and let Dr. Litwin and his associates make the difference.
Well, on behalf of UCLA Urology, on behalf of the field of urology, on behalf of patients and physicians everywhere, I want to thank you personally for the fine work that you're doing in raising awareness and attention to this, Steve. Thank you very much.
Appreciate it.
Godspeed.
Thanks.